Hello and welcome to the latest edition of Lovegrove on Health. My name is Dominic Lukes. I'm the Product Marketing Manager here at Skills for Health. And joining me as always is Andrew Lovegrove. How's things with you, Andrew?
Hi, Dom. Good to be with you again today. Things are really good. September is now very much upon us. What a month it's been with things in the news and in the world. And there's that sort of feel of autumn in the air this morning. The wind's a little cooler than normal, but, you know, just part of the ever seasonal aspect of life. But, you know, really good to be here with you here today for this very special episode.
Yeah, absolutely. It feels ages since we've actually done a podcast again. We'll have to get back on that train. But yes, absolutely. We've got another special guest joining us for this issue. Sam, would you like to introduce yourself?
Hi, I'm Sam Hepplewhite, and I'm Director of Prevention and Partnerships at South East London Integrated Care Board. Obviously, we became a Integrated Care Board on the 1st of July, so I have to keep reminding myself I no longer work for a CCG anymore, but it's lovely to be here.
Great. That's great, Sam. And I think one of the strap lines I've always had is organisations change, but functions remain. And the NHS certainly likes to rebadge itself on a fairly frequent basis. But, you know, obviously the whole agenda around integrated care systems and integrated care boards is quite an exciting time for the NHS. And it'd be good to, you know, speak to you this morning. And we'll pick up a conversation with you very shortly. But Dom, I think today we're going to talk about workforce planning again, which is something we've covered in previous podcasts. But we really want to talk to Sam today about some experiences from her perspective working in the capital, and really to talk about some of the ongoing challenges, particularly within primary care. You know, and I'm almost fate has worked with us that it's the 22nd of September today as we're recording, and primary care is in the news this morning. The new Secretary of State I saw on the television whilst I was having my bran flakes this morning talking about primary care. So it feels a really timely conversation. And I think, you know, we've talked about the ongoing challenges of primary care and the workforce, but also the need to think about how we configure and plan our primary care workforce more systematically. And I think we need to do that if we stand the best chance of ameliorating some of those challenges. So we at Skills for Health, we've been doing some work with Sam in South London, working with a number of the primary care networks, thinking about their future workforce, and how they will better plan for it. And that's really going to be the majority of the conversation today, isn't it, Dom?
Absolutely.
We'll have that conversation with Sam, and hopefully we'll find things of interest for our listeners and be able to understand what's happening in that part of the world, but also from people who are working with real primary care colleagues, and I'll have a much better understanding of some of their challenges.
Yeah.
Fabulous. So, Sam, just to add my own welcome to you joining us here today. And I think we've talked on this podcast previously about some of the known challenges of primary care from a workforce perspective, the challenges we've got around access to primary care, the ageing primary care workforce, people retiring. And those are sort of, you know, I think are almost just taken as givens in terms of primary care sort of nationally. But so I'd be really interested working, you know, in the part of London that you work in, you know, some of the key challenges that you're noticing. Is there anything particular that you're noticing in London that either confirms the national agenda, or are there things where you may be against the trend. Just really interested to know what your thoughts are.
Yeah, thank you, Andrew. So I think probably we're very similar to the rest of the country, as in we are seeing a real pressure in primary care. And that's really because when I say primary care, I mean general practice, as in there is a lot we are asking them to do at the moment. And when I say we, both nationally and locally, primary care and general practice in particular has got a unique position in the NHS. They are often seen as the first port of call for many people in the community. They still have a high level of confidence and trust, even though in the last year or so, I think that has dipped a little bit. But there are a significant amount of people that still trust their GP and the staff. So I think we are still putting and asking them to do more and more for that local population. Just for example, there's a huge amount around the vaccine programme. So at the moment, we've got 3 vaccine programmes that we're asking primary care to help with. So COVID, flu and the immunisation for children. So we've got a polio programme at the moment, and we're about to move into an MMR programme. And that's just one example of how we keep asking primary care, because of their unique position in the community, to do more and more. That is having a huge pressure on the workforce. So we're seeing not so much of a problem with regards to recruitment, it's retention, and it's the environment that people are having to work in, and the high level of expectation from the public, which often they just cannot meet those expectations. And then there's a feeling that actually it's very, very difficult to continue to do a job when you don't feel like you're doing a good job. So I don't think we're any different there. I think also with the layering of primary care, so general practice, we've got 200 odd general practices. We then have 35 PCNs, and then we have 6 or 7 federations. Now, whilst they are just layered on top of each other, with the arrangements we've got in place, it's still the same workforce. There isn't a separate workforce in each of those areas. And often when we talk about, we'll ask the PCNs or we'll commission the PCNs to do that, it's recognising that it's still the same workforce as if you were asking general practice. There's not another cupboard of people. So I think sometimes the sheer infrastructure, the way we have ourselves organised, doesn't help general practice and primary care, because it sort of hides the fact that there is only one workforce. I think we, like everybody else, have struggled a little bit with the additional roles. So whilst there was a great idea to get additional roles into general practice, I think the way that it was implemented just tied people up a little bit, in that the protocols and the guidance that had to be met, it didn't really give general practice that freedom. So I think we had great expectations with those additional roles scheme, and I think that's probably fallen short. And also, I suppose what we all know is that for the PCNs, the network DES comes to an end in 18 months' time, and we still don't know what the future of that's going to be. So we've got, on the one hand, rising demand, rising expectation. We've got an uneasiness, and because of the fact that there is probably a less than clear view of what is coming and what's still going to be available. And then what we have also is obviously the fuller review that has come out that sort of starts to paint a picture of the future. So that also is something that general practice needs to start thinking about, whether it's an individual practices or PCNs moving into integrated neighbourhood teams. That's going to take another set of the workforce to think differently. So there's quite a lot going on in primary care at the moment, and all of those things have an impact or a consequence for our workforce, whether it's workforce planning or it's just the way our workforce works.
Yeah, and I think there's so much there, Sam, that just resonates with me. I think the additional roles scheme I'll share a very quick anecdote with you. I'd been to our head office in Bristol, and I was coming back on the train, and it was sort of middle of the day, so the train was relatively empty. And in the seat across from me were some GPs in training who were on their way to a meeting in Birmingham. I think it was to one of the deanery meeting. And as they were talking, I couldn't help but overhear the conversation, because they were talking about some of the new roles that have been brought into primary care. So there was a paramedic who'd been brought in, there was a medicines management pharmacist, there was an MSK physio, and they were all saying, it sounds great that we brought these people in, but nobody really knows what to do with them. Everyone was a bit unclear about, so, okay, you're this person, this role, but how does that integrate with the existing workforce? What can you do? What can't you do? How long are they going to be there for? There's funding to an X date. Well, what happens on X+1? And so can we only do short-term planning? And one of the GP registrars was saying, it feels as though it's more trouble than it's worth. And at that point, I'd sort of stayed quiet until that juncture. And I'd sort of said, forgive the eavesdropping, but this is a real pertinent topic of conversation for me. And I think initiatives like the additional roles are well intended, and people can see sort of like from an overall perspective why those new roles, ways of working, would add value. But for me, Sam, it's the devil's in the detail. It's in the planning about, okay, so here is a role. How does it work alongside? How do we make sure the care pathways we've got are designed to provide that the seamless journey for the patient, but also that it adds value to the workforce overall. And I don't know what you think, Sam, but some people have thought about it more systematically, where there are other people have almost, with good intentions and well intentions, have perhaps thought, well, we'll have one of those and one of those because we want to make most use of the available funding that we've got. I don't know if that rings a chord with you or not, Sam.
Yeah, and I suppose that comes back to the maturity of the primary care networks. And we all know that there are a range of different maturity of primary care networks and capacity and capability to make some of those decisions. And so I think definitely there has been examples where primary care networks have recruited who's available. And then they've thought, how do we integrate those into a workforce? I think what was not really thought through, and it's unfortunately now playing out in some of our PCNs, is exactly the input that you need to put into developing these people. You can't just expect an individual who is doing a role that's never been part of a primary care team to just be lifted and shifted into that team and it work. There's support, there's development. Primary care is completely different to working in other parts of the NHS. You don't have that massive infrastructure that you do in a hospital that supports you. You're often working on your own. I mean, obviously the responsible clinician is close by, but they might not be with you. I think from an individual's perspective, it could be quite a lonely place. If you're the only paramedic that's in that PCN, or you're the only first contact physio, that's quite a lonely place to be. So you also have to think about the individual as well as the patients, as well as the wider team. It's the individual. How are we helping them to feel that they are part of a team, that they understand what their role is, what their contribution is, and how they are able to use their expertise, because all of these people are, professional and are trained in their own area of expertise. How can they contribute to that wider PCN team, that wider general practice team? Because it's all well and good recruiting, but keeping people in a place where they are happy, they feel fulfilled, they're developing is something else. And I think that's one of the probably the areas of weakness in this scheme. It didn't necessarily think, how long does it take to integrate new roles into a team?
Yeah, and I think, there's been several people who've written about, yes, recruitment is important, but retention is absolutely vital. Recruitment has a cost, on many levels, and can be calculated in many different ways. And yet creating that environment where somebody wants to stay, where somebody knows what their zone of responsibility is, how that role interfaces, but also some very basic things. I was talking to an MSK physio who sort of turned up on their first day, and there was nowhere for them to work. They'd got no access to sort of IT, and it was kind of like nobody had really thought about it. They hadn't willfully not thought about it. It's just it hadn't been thought of. So, it's like turning up at somebody's house and they don't expect you. There's an inbuilt awkwardness almost from day one, minute one. And, is that the best environment where people will want to stay and remain?
Yeah, and I think the other thing was around preparing the public for all these new roles. So, traditionally you wouldn't see a paramedic as a practice. There are some practices that have never had physios in their practices, and I think there was a little bit of could have been done more at a national level to say your primary care, your general practice team might look different.
Yeah.
And these are the sorts of people that you might see there, and it's okay. They are professionals. They are part of the practice team, but that's going to be different to maybe when you went to the GPs 5 years ago, where you saw a GP or a nurse. In your mind, many people's minds, that's the primary care workforce. And so actually what we're really struggling with is also people understanding why they're seeing somebody else. Why would they get diverted to somebody else who isn't a GP? So we're having to do quite a lot of work in South East London, I'm sure others are as well, in providing that assurance, but in providing that information to the public to say, you might, on this occasion, if you go with this particular condition, you might end up seeing this particular professional, and it's okay.
Yeah. And I think in workforce planning, we very often talk about, the right thing at the right time, at the right place, the right member of staff for the right, episode of care. And so, seeing a physio, seeing a medicines management pharmacist is probably the best outcome for that particular, that episode. So I always talk about my own experiences. So my mum got an invite to go and have a medication review with a pharmacist in the practice. And she's like, why aren't I seeing the doctor about this? Why aren't I seeing the pharmacist? And I was able to explain to them, well, in terms of medication and drugs, the pharmacist knows more, is probably better placed. No disrespect to GP colleagues, by the way, but it's probably better placed to do that, to make sure that you're on the right medication, that, you're taking it as you should, explore any side effects, etc., that could then, if there are problems, lead on to an appointment with another clinician. And I think that it's unfortunate that we're workforce planning and thinking about new roles in a time of kind of a bit of a crisis in the GP workforce, or, maybe crisis is too strong a word, but we've got recruitment and retention challenges within the GP workforce, and that people join sort of 2 and 2 together and make 5. Oh, there's fewer GPs. I'm being fobbed off by seeing somebody who is not a GP, so therefore I'm getting a lesser experience. But actually, I think these changes, the way we have a different workforce, I think are necessary and needed almost in spite of any challenges. But I agree. I think almost the communication and engagement piece with the population and with people is absolutely vital if, to deal with some of those issues.
I think also there is something about the clinical teams in general practice recognising that they might have to let go a little bit. So this is not every single practice and not every single PCN, but I think it is recognising that GPs will have to work differently. They really cannot continue to just absorb all of the demand that's coming their way, that there are going to be other professionals that can help them with that. And that would take a slightly different way of working. And, you hear of these new ways of working often bandied about, but this is for the GPs and for the general practices and the PCNs to work out what their future operating model is going to look like. I think there's a position where we have to provide them also with the confidence that they can trust some of these other professionals because they're new. It's exactly the same feeling as the public, and so I think it's recognising there's quite a lot of, this is the wrong word, but OD, organisational development that needs to go alongside this, so that we take not only the public with us on this journey that's going to make general practice and primary care teams look differently, but we're taking the teams with us and they recognise it and they feel confident, because if they're confident, then the public will be confident.
Yes. Confidence gives off confidence. And I think that's a really interesting point there, Sam, that you've got the whole workforce modelling and the redesign of the workforce, but you can't ignore the service model and the operating model of the service, because there's lots of tradition associated with primary care in terms of, a colleague once said to me, I'm a GP, I see the world in 10-minute slots. That's how I view everything in kind of that 10-minute slot. And I certainly don't advocate throwing, the who out with the bathwater, but I think we have to look at the way we, if the demands and the complexity that's being placed on primary care is changing, growing, getting more complex, then the service model, that service offer, we can't not look at that, in my view. We have to look at that as well, because just bringing in different roles and trying to get them to fit into that model, it just feels like a square peg in a round hole to me, Sam. I don't know what you think.
Well, I totally agree. And I think that we also have to do some future proofing. So, yes, we are where we are with general practice primary care at the moment, but we know it's going to have to keep continuing to evolve and change. And I think that the fuller review starts to articulate what that looks like. I think, it could have gone a bit further, but, these integrated neighbourhood teams that have started to be explored in the review, the integrated urgent care, the same day demand that has started to be explored there. So I think, as with everything, planning is not about what we're going to do next week. It's also thinking about what we're going to do to 2 to 3 years' time. And that's where the additional roles didn't help, because it came in and it was there. It didn't think about how are we going to mature that over a number of years, because that's how long it takes, and what would primary care look like if these became integrated into the team. So I'm absolutely with you there, but I do think we've got to start thinking differently about what the model is going to be and start planning accordingly, not just where we think it's going to be in the next couple of weeks.
Mm-hmm. And I think, going back to a point you raised earlier, Sam, that really resonated with me, was around kind of like the infrastructure in primary care, or almost the lack of infrastructure in primary care. That we've got PCNs, we've got federations, etc., but they are the same people. They are the PCNs are the practices, and the practices are the PCNs. There isn't that sort of that structure, that enabling structure that you may find in secondary care organisations. So I think that one of the challenges is we've got people who are literally delivering the here and now and the day to day, and that, you know, the people requesting appointments this morning aren't suddenly going to disappear, but also have your eye on kind of like the future. And it's how, you know, that can be quite discombobulating. So how do we actually, you know, they're not mutually exclusive. It's about bringing those two elements together, and maybe you mentioned sort of organisational development, and I know some people think that's quite a hip, trendy, you know, nice to do, but I would argue organisational development is where a lot of the real hard work sits, because it is about how do we change. I'll use the word organisations. I'm giving sort of the inverted commas sign here, but how do we support organisations to change and be fit for the future? Because they're not going to do it in a vacuum.
No, absolutely. And I think that cultural shift is something that we have possibly not done well in the past when it comes to general practice and primary care. So again, I do welcome the Fuller Review, but I do think that that's a gap in the Fuller Review recommendations, because it doesn't recognise the huge cultural shift that we have to do this. It doesn't recognise that would then take a group of people leading that to change ways of behaving, ways of working. There's a massive shift required that, as you say, the same people that we are asking to deliver, all that we're asking them to deliver in general practice services, would then have to be able to lift themselves up and to be able to help us to do that, because it has to be influenced and shaped by the people that are actually doing the job at the moment. And I think what we also have to do is they have to have time to develop the relationships with the rest of the system. You know, the interfaces with acute services, the interfaces with community, the interfaces with mental health, interfaces with voluntary sector. That's what's going to make a sustainable general practice, primary care, integrated neighbourhood teams, whatever you want to call them. That's what's going to make it successful, not just moving a few people around in general practice or getting a few extra additional roles in. It's going to be those relationships with the wider system that's going to make the real difference for our residents, and then also be able to attract and retain that workforce, because it's going to be a so much more rewarding place to be, because you're able to look after that individual in front of you rather than having multiple handoffs and having to negotiate the system yourselves. So I think I understand what you're saying. It does sometimes feel a little bit pink and fluffy, OD, but I think actually it's the thing we don't do well. And that's why we're sitting here with not having integrated teams, because actually it's too difficult at times. The rubs between the different sectors, the fact the relationships aren't there, the fact that we haven't invested in taking the time to get it done, means that we are where we are. So I would absolutely support putting some resource and some time behind and enabling those leaders to be able to do that.
Mm-hmm. And I think, Sam, so we started a relationship probably around a year and a bit ago when we were asked to come in and help South East London with workforce planning, to help develop workforce plans at sort of the primary care network level, and we've worked with a number of those networks. And it's interesting as we move on. I'd just like to talk about that in a little bit more detail, because I think you find that the workforce planning, one of the things about workforce planning is it's called workforce planning, and people get this sort of this image in their minds of somebody drowning in spreadsheets in a little cupboard, sort of auguring numbers and, you'll come up with the answer and it'll be 42. But for me, workforce planning is not so much a technical activity as it is a behavioural, organisational, because anybody can come up with a number, anybody can configure a model, relatively speaking, but it's how you then implement that and and the work you do to get to that point. Because I think of the number as the middle bit, but there's all the conversations that lead into that and that lead out of that. And I suppose just some of the work that we've done with you, Sam, I'd just be interested on your reflections of that. Maybe some of the things that confirmed your thinking or challenged your thinking, or things that you were surprised by. We're just really interested for our listeners to maybe share some of the insight working with us on those workforce plans, but from your perspective. I know you said the CCG then, but I think it was a CCG at the time, so I think I can say that. But from your role now, just be really interested just to get your thoughts, really.
Yeah, so I think the first thing I would say is that I had to manage my expectations with this programme, not because of Skills for Health, but really I've realised as we went through that this was the first step in quite a long process. So I think it's recognising exactly what you said, Andrew, that there hadn't been any real investment in workforce planning in primary care. It hadn't even been talked about, recognised that there was a need. And so we started this programme, and I very quickly realised that it was fantastic, and it was starting them on that journey, but it was only the start. And what I also realised was very quickly that the PCNs that took the time and the space and because it is luxury of time, really, I think we gave them with this programme to think about it. And as you say, that first bit, taking the time to think, taking the time to discuss it, taking the time to build the relationships within the PCN by exploring workforce and understanding people's different perspectives and their views and their opinions. That was a huge gift that we gave to the PCNs, and some took it up and some didn't. Some thrived in that environment and some found it really, really challenging. And I suppose coming back to our expectations, we probably didn't think through enough before we started this process, just the realism of the situation of what had happened before and what really hadn't happened before around workforce planning. I think also what we didn't really appreciate, but came through as part of the programme, was really the lack of experience and capability to think about workforce planning in primary care. So there was a real gap there in their knowledge. And again, some people embraced that and saw it as a huge opportunity to learn more. And others, it was just too difficult. Have to recognise this was also, we started this process just before the pandemic. So actually, a number of the PCNs were being asked to do lots of different things at the same time. So we had obviously the COVID vaccination programme going on. So there was lots of conflicting stuff going on at the same time, I think, Andrew. And so for those PCNs that managed to lift themselves above that to continue with the programme, I think, that was fantastic. I think the way that the programme was delivered with some dedicated time, the same people went to the various workshops. I think that we talked about that a little while ago. That confidence and that trust was built in quite quickly. And I think that the level of expertise of the Skills for Health team and their understanding and experience of working with general practice and PCNs previously came through. So there was quite quickly a level of trust and confidence in the people that were at the front of the room. It was often a virtual room, but it was at the front of the room. And I think that certainly helped. I think we probably, with hindsight, could have done a bit of warming up as well. We very much did this from a, who's interested, we'll play with those people that are interested most. And that certainly was good, but probably we could have done a little bit more of the warming up and getting them ready for it, managing their expectations. We had a very clear brief from Skills for Health, which we obviously shared. But my reflection also is that we could probably have prepared them a little bit more for that. I think what you've left us with, because we have completed two rounds, what we have been left with is a group of PCNs who are probably in a better place to start thinking about what this integrated workforce plan might look like. So what they were thinking about as part of the programme was what their primary care network workforce plan and planning process might look like. I think we've now given those PCNs a real basis for thinking about the next stage, which is what could that integrated team look like? How do, because there was a great part of the programme where you were encouraging them to look at their population health. What was it telling you? What was the data telling you with regards to what would your workforce look like? And I think some of those principles have absolutely landed within our PCN. So actually it doesn't matter that now they're thinking wider than just general practice. They're thinking integrated neighbourhood teams with mental health and acute and community. But the principles remain the same. And I think that's probably the lasting legacy of this programme, is that you left us with the ability to adapt the model that you gave us to be able to make it future-proof. And I think quite often that's not the case when you work with people. They give you a model for that day that works, but actually you can't then adapt it. So I think we're in a much better place than we would have been if we hadn't have done this programme. I think we've still got lots to do, and it's still, I think, generally we find workforce planning quite challenging, don't we, in the NHS? But certainly this is so important that we are absolutely committed to continuing that journey with our PCNs and hopefully using the skills of the wider system to keep on building on that.
Yeah. I mean, thanks for that, Sam. There's so much there. I think workforce planning it's not an easy ask. It's something. It's never completed. I always say anyone who tells me a workforce plan is complete, I am immediately suspicious, because for me it's an ongoing, iterative process, and a good workforce plan should be flexible because we have to respond to change. We have to respond to, challenges. I say to people, nobody saw COVID coming. So we have to respond to things that we're not going to be able to foresee. I sort of just made a quick note then, and I wrote down trust and confidence, because I think those are key ingredients. I think they're key ingredients when you bring in, strange. I always say I'm a stranger. I'm a guest into an organisation, and it's like being invited to somebody's house. You have to build trust and confidence that you know what you're talking about, but you are also going to add value to what it is you're doing. And so it's really heartening to hear that we were able to do that. But I think in doing that for ourselves, getting people to build the trust and confidence to work with each other, because obviously, Skills for Health will exit stage right at some point. It's what you've then got left. And if you've built people who can trust, got confidence in each other to work together, that for me is, a real crucial ingredient for, well, not just for, I think you need it full stop, but I think for workforce planning, absolutely. And it's also that planning for the plan. So we advocate our 6-step methodology around workforce planning. And for me, that's step one is so, so vital about knowing who your stakeholders are, knowing what the aims and objectives of your plan are going to be. Because without that, you're just building everything on sand, in my view. So actually spending the time, and I don't think you have to worry too much about getting it right first time. I think, you said, there are things, on reflection, we could have done differently. I think that's great. I take those as real positives, Sam, because for me, that's it show that you really absorbed, the workforce planning cycle, and I can identify the things you do differently next time. So I think, the fact that you've already almost got those lessons learned that you can then use when you're working in the future, embed those. I think that's to your credit. So I think recognizing what we would do differently. I think you're right. Being realistic, a workforce plan's not going to solve everything, and you're not going to solve everything first time. So I think being realistic is a real key element here. But the trust and the confidence of working together, that doesn't just happen. And I think that shared endeavour, that shared purpose, helps to create the relationships which create the environment for, embedding, good workforce planning. So, Sam, I'm conscious that we are very near the end of our time together now. I suppose, just to give you the microphone one last time, are there any other points you think working with us that you'd like to share? Are there any other sort of success ingredients for workforce planning in primary care that some of our listeners may benefit from that we haven't covered so far in our conversation?
So the only other thing I was going to say with working with Skills for Health is that one of the comments that sort of resonated with me from one of the PCNs was they felt it was a knowledge exchange was the word that they used, which they felt was different to some other interventions they'd had. They felt that the facilitators, the managers that they had really was sharing their knowledge and their experiences, but was not holding anything back. So I thought that was worth sharing, really, that the approach was very much a knowledge exchange. And I think that especially some of the support recognised that they were learning from the PCNs on just how general practice was working. So it felt like a two-way relationship. It didn't feel like it was us sitting in a classroom being dictated to on how to do it. So I think that's important. And I think the other thing, just to say generally, is that we just have to have a mind on the future. I know I've said this a couple of times now, but the general practice model is going to evolve. It's going to change. Hopefully general practice PCNs will shape that, and it won't be because we have a new contract in place or we've been told that's what we need to do. And so therefore the workforce needs to adapt. And I think we just can't be sitting back thinking that our future of general practice is going to look very similar to what it does now. It would be great if that could be shaped by the current general practice, PCNs, and then using the workforce planning to enable that to happen, to see it as an enabler, not as you said, Andrew, as a spreadsheet filling in some numbers, that we actually take the opportunity with what we have now to get ready for the next 5 to 10 years.
Absolutely, Sam. I think my take from today is we have to live today and make today the best experience we can, but recognise that tomorrow and beyond will need to look and feel different. But let's grasp this ourselves and let's design what that future needs to be. And if we do that, we'll have that sense of ownership. We'll also have that sense of we are co-creating the future to make this a better place for the people and the populations that we serve, but we make it a place people will want to come and work in the primary care space that will build that sustainability of the workforce for the future. So, Sam, thank you so much for joining us today. It's been really good to speak to you.
It's been lovely to meet you both. Thank you.
So all that's left for me to say is thank you very much for listening to this latest edition of Lovegrove on Health. A reminder that our podcast can be found on all the major platforms, including Spotify, Amazon, Apple and Google. And that's where you can also subscribe so you never miss an episode. You can also find the recordings on our Skills for Health website and social channels. Until next time, many thanks.
Bye.